Lobes and fissure in RTND left lung. RT 3 lobes upper middle lower, 2 fissure oblique ND horizontal. Left 2 lobe upper lower, 1 fissure horizontal. Which lobe of lungs is not visible clearly on X-ray? Why? Lower inferior, cause it's located posterior. Do lateral X-ray or court for it. Or hear it in subscapular, infra-axillary area. Appearance of azygous fissure, percentage of PPL who have it. Tadpole appearance, 1–2% PPL. Azygous vein firms head of tadpole. Phantom tumor or pseudotumor etiology, what is it? Resolution. It's due to fluid accumulation in horizontal fissure. Etiology CCF. Resolve with diuretics. Its X-ray look like well-defined mass-like opacity which clear on use of diuretics in 2 to 4 week. Structures in hilum of lung and relation in right ND left. Pulmonary artery, pulmonary vein, bronchus, lymphatics, PA anterior to bronchus on RT lung, PA above bronchus in left side. Causes of hilar enlargement. 1. Hilar lymphadenopathy TB, sarcoidosis. 2. PA dilatation. 3. Mediastinal mass. 4. Mass in bronchus. Weber's generation of airways. Total zones, names. Total zones -23. Trachea 0th zone. Conduction zone 1 to 16. Respiratory zone 17 to 23. Order of Weibel's generation of airways. Trachea, bronchi, bronchioles, terminal bronchioles conduction zone up to here. Respiratory bronchioles, alveolar ducts, alveolar sac. Types of bronchi. Primary principal main. Secondary lobar, tertiary segmental. Right versus left bronchi. Right bronchus is wider, shorter, steeper, and at acute angle. That's why foreign body impaction is more in right side. Functional unit of lung is secondary pulmonary lobule, 3 to 5 terminal bronchioles enclosed in CT septa. Pulmonary artery is intrasegmental but Page's vein is intersegment. Anatomical unit of lung is called bronchiopulmonary segment BPS. It's a segment which is supplied by tertiary bronchi. BPS of left and right lung. Total 10, right 3 in upper lobe, 2 in middle lobe, 5 in lower lobe, left 5 in upper lobe, 5 in lower lobe. Which BPS is involved in aspiration in supine position? Post segment of right upper lobe greater than superior segment of RT lower lobe. Which BPS is involved in aspiration in standing position? Basal segment of lower lobe. Cells in conducting airways. 1. Basal cells. 2. Goblet cell. 3. Clara club cells. 4. Kulczycki cells. Which cells of conducting airway are stem cells, progenitor cells during lung injury? Basal cells. Which cells of conducting airway does detoxification function, and progenitor for bronchiolar cells? Clara club cells. Kulczycki cells function. Has dense core vesicles with serotonin calcitonin CGRP, calcitonin gene-related peptide, IMP in migraine. Cartilage, smooth muscles, goblet cells present or absent in trachea, bronchi, bronchioles. Cartilage present in trachea and bronchi, absent in bronchioles. Smooth muscles absent in trachea, present in bronchi and bronchioles. Goblet cells present in only bronchi. Trachea contain which cartilage and epithelia? Hyaline cartilage. Epithelia 1. Glandular mucus. 2. Lamina propria, pseudo-stratified ciliated columnar. Epithelium in bronchus. Upper part, pseudo-stratified ciliated columnar. Middle part, simple ciliated columnar. Lower part simple cuboidal. Most potent constrictor and dilator of bronchial smooth muscle. Constrictor, leukotriene. Dilator VIP, vasoactive intestinal peptide. Which test is done to check hyper-responsiveness of airway? Methacholine challenge test. Cilia are present up to where? Present up to terminal bronchiole. Condition with defective mucociliary escalator mechanism. 1. Immobile cilia syndrome. 2. Cystic fibrosis. Both are AR. Immobile cilia syndrome pathology, age, investigation. Defective dynean arm of cilia. Age -5 year. Recurrent sinusitis, otitis media. Investigation, nasal nitric oxide low. Associations with Kartjener syndrome. Kartjener syndrome. Triad of sinusitis plus bronchiectasis plus situs inversus. Plus male infertility. Cystic fibrosis gene, and features. CFTR gene F508 mutation. On chromosome 7, chloride ion defect. Normal cilia but thick mucus. From trachea to alveoli, airway diameter, total cross-section area, velocity of airflow, turbulence effect. All decrease except cross-sectional area. Relation between radius, resistance and flow. Max radius, least resistance, max flow. Area of max resistance. Bronchi greater than terminal bronchioles due to parallel arrangement of smell airways. Value of Reynolds No and type of flow in various zones. Less than 2000 laminar flow, alveolar duct, alveoli. 2000-4000 transitional, respiratory bronchioles. Greater than 4000 turbulent, trachea, bronchi. Alveolar cells. PAM pulmonary alveolar macrophages. Pneumocystis 1 and 2. Pneumocystis 1 and 2 comparison, percentage, type, effective bleomycin. Type 1 is 95%. It's squamous, type 2 is cuboidal. Type 1 gets injured by bleomycin, type 2 undergo hyperplasia. Which type pneumocystis is prone to oxidative damage? Type 1. Which type pneumocystis produce surfactant? Type 2. Markers of type 1 pneumocystis. Aquaporin 5, caveolin 1, carboxypeptidase M. Markers of type 2. Surfactant protein A, B, C, D. Surfactant proteins involved in innate immunity. A, D. Storage bodies of surfactant in type 2 pneumocystis are called lamellar bodies. Substances that increases or decreases surfactant production. Increased, steroids plus thyroid hormone. Decrease insulin. What clears excess surfactant? GM-CSF.